is all. It begins there and ends there. So we should not confuse IHCP with anything else. Any associated feature, we have to work out that. So that is the only message, that is the take home message I am giving right from the very beginning, and the presentation will run through that only. So this is shown that the incidence varies from 0.5 to 15%, and in Indian and Asian populations, I told you, it's a pruritus and elevation of serum bile acid concentrations, typically developing in late second or early third trimester, or till the late third trimester. It's a disease of later half of the pregnancy. So the incidence varies from 1 to 27.6%. In Indian, Asian and Pakistani Asian population, it is 1.2 to 1.5%. That makes it around 15 women per 1,000. And looking at Indian population, it's not a small thing, it's a big thing. So seasonal occurrences and risk factors are there. For unknown reason, the disease occurs most commonly in winters, and like in countries which are more cold, Sweden and Finland. So etiology could be a genetic susceptibility, estrogen and progesterone, because pregnancy is rich in them, and environmental factors. Now we know they are contributors, and underlying liver disease will definitely, because liver is getting affected, and if it is already sick, then it becomes more sicker in pregnancy. So evidence of familial clustering is increased risk in first degree relatives. It has been seen. Estrogen, basically estrogen is more responsible, and environmental factors, low selenium in food and vitamin D deficiency could be the contributors, and underlying liver disease, as I said, if the liver is already sick, it becomes more sicker in pregnancy. So estrogen and progesterone causing ICP would be more common as we see, it is more common in twin pregnancies because more of hormones is there. In IVF cycles, if there is ovarian hyperstimulation syndrome, again this will occur in the first trimester, but it will be a very transient feature, it will go away. And cholestasis occurs in individual taking estrogen and progesterone contraceptives as well. So the increased risk of ICP is unknown, though exogenous progesterone supplementation during pregnancy is not to be done if you suspect there is a hepatic disorder. So hydroxyprogesterone K-Pro8 reported a 5% incidence of pruritus in patients. So that is, we don't know was it ICP or per se. So that is the reason why it is not to be given when there is history of jaundice in pregnancy, liver tumors, active liver disease, or these are the contraindications to the therapy. So the clinical findings, I said typically it begins with pruritus, which is really very big nuisance for the patient, and it occurs mostly on the palms and soles, and it is more towards the night time. Often generalized, but starts predominantly on palms and soles, worse at night. Rarely we find, these are rare, this is the most commonest feature. Rarely we find right upper quadrant pain. Maybe it is associated with a liver disorder which was there, nausea, poor appetite, sleep deprivation, and steatorrhea because the bile acids are not being absorbed. Encephalopathy or other stigmata, if they are present, then we really have to think and look for other etiologies. So transient first trimester symptoms have been linked to ovarian hyperstimulation, as I already said, after IVF. So physical examination, not much because jaundice is also rare. So what would be, you will see scratch marks. So scratch marks because the patient is having lots of pruritus, excoriations, prurigo nodules secondary to scratching. Jaundice occurs only in 14 to 25%, typically occurring later. That is 1 to 4 weeks after the onset of itching. Jaundice without pruritus is rare and should prompt other investigations for other causes. And lab findings, elevated bile acid is the marker. For presentation, it is seen in 90% affected pregnancy. Pruritus may precede, not may, it always precedes by 2 to 4 weeks with the lab abnormalities, and total and direct bilirubin concentrations are increased only in 25% of cases and never more than 6 mg%. So serum aminotransferases are also raised, usually twofold to the upper normal, limit of the upper normal. At times, rarely it can go into thousands as well. And alkaline phosphatase, because placental contribution is lot, so it is seen to be increased 4 times, maximum up to 4 times from the upper normal limits. So the diagnosis, these are the differential diagnosis from pruritus gravidarum, atopic eruption of pregnancies. These are pruritus, they have similar presentation to intrahepatic cholestasis of pregnancy, but liver functions is normal in pruritus gravidarum. In atopic, there would be history of other allergies. In polymorphic eruptions of pregnancy, this is pruritus seen in 3rd trimester, typically affects the lower abdomen and umbilicus. And pemphigoid gestationis, it usually comes with a rash which has got papules and macules. And pruritus, prurigo of pregnancy, pruritus usually in 3rd trimester, groups of red-brown papules on the abdomen and extensive surfaces are seen. And pruritus, folliculitis of pregnancy, another differential diagnosis, follicular papules and pustules which may be filled with pus, but the pus is usually sterile. So other differential diagnosis would be which are diseases specific to pregnancy, that is acute fatty liver of pregnancy. The lady is definitely more sick over here. New nausea and vomiting occurring in the 3rd trimester are not because of hyperemesis gravidarum. Women with AFLP are more unwell and often have associated renal impairment, coagulopathy, hypoglycemia and preeclampsia. Help, another reason where we can see hypertension, proteinuria, headache, epigastric pain, visual disturbances in 2nd or 3rd trimester. Presentation is nearly in the same bracket, but they are preceded by more clinical symptoms. Hypertension and proteinuria are predominant features. Hyperemesis gravidarum, it is more towards the 1st trimester of the pregnancy. Presentation in early pregnancy and abnormal liver functions. Tests resolve with successful treatment. So other differential diagnosis would be general diseases which affect the liver, that is viral hepatitis. It can be associated with jaundice, nausea, vomiting, and systemic symptoms are there, and we can have viral markers which are positive. Primary biliary cirrhosis, again the symptoms occur before the pregnancy and they are associated with antibodies. Autoimmune hepatitis, again the symptoms are associated with autoantibodies. Drug induced injury, there would be a history of drug intake before the symptoms and there could be biochemical abnormalities. Biliary obstruction, then we have abdominal pain and pale stools and dark urine. Liver ultrasound can be, we can see the abnormalities on liver ultrasound. Veno-occlusive diseases, thrombosis can be demonstrated on imaging, and thrombophilia, it usually presents with abdominal pain, distension and ascites, jaundice and GI bleeding. So the fetal effects now. In IHCP, the mother is only symptomatic and she is troubled, although not much of morbidity for her. But the baby suffers sudden stillbirth, could be meconium stained liquor, and it could be a preterm delivery. These are the only three things which affect, and it basically what happens is it goes into sudden fetal death without giving us a warning. That is the reason why we have to time our delivery and monitor such patients very, very carefully. So magnitude of risk is iatrogenic preterm births. These are the odds ratio of 3.65%, spontaneous preterm birth, and there could be induced preterm birth as well. And spontaneous would be 13.4, and meconium stained amniotic fluid, the baby might need a NICU admission. Stillbirth rate, risk of stillbirth is directly proportional to the bile acid levels. So if the bile acid is less than 40 micromoles, it is only 0.13%. When it is between 40 to 99 micromoles per liter, it doubles nearly. It becomes 0.28%. But if it goes to greater than 100 micromole, then it rises multifold. That is around 6 times, 3.44%, as compared to when the levels are lower. So it is directly proportional. So maternal treatment is basically we are focusing towards her symptoms, which is pruritus, and we are trying to see that bile acid levels also fall. So we can reduce the risk of perinatal morbidity and mortality. So ursodeoxycholic acid is the only time-tested drug safe in pregnancy. Optimal dose of starting is around 10 to 15 milligrams per day in 2 to 3 divided doses, usually 300 BD or 300 TDS can be given, and we assess the patient after 2 weeks or maybe 3 weeks, and if she is not relieved, we can go up to maximum dose of 25 milligrams per kilogram per day. And evidence are there is modest improvement in the maternal pruritus score on a 100 mm visual analog score. So pruritus score does improve. Lab abnormalities, that is bile acids and serum transaminases, may improve or may not improve, and there are non-significant benefits to the fetus, which like we say, the fetus is having greater mortality and morbidity, but the changes UDCA brings about is minimal. So we have to, again, we are just focusing with UDCA, we are focusing towards the mother, seeing to it that her symptoms are relieved, so she can carry her pregnancy few more days very safely. So non-significant trend towards reduction in stillbirth, in neonatal admissions, in spontaneous preterm birth, and there is a total reduction in spontaneous and iatrogenic preterm birth, but these all changes are very non-significant with UDCA. So pre-treatment and post-treatment lab monitoring, before treatment no additional lab testing is required, other than that what we have done for IHCP. Follow bile acid levels. Clinical decision making is based on highest total bile acid level at any point during pregnancy, and maternal obstetric history or symptoms. Suppose a lady has a previous IUD at 35 weeks and was associated with probably IHCP only. So now we are very alert. We start investigating her from 32 weeks onwards, because this is because it has an genetic predisposition and hormones. These are two things which will keep on recurring again and again in the same woman. So she is at risk of developing IHCP again in this pregnancy, and she needs more monitoring. So repeat evaluation of maternal total bile serum admit concentrations can be considered as often as weekly due to significant increased risk of stillbirth in patients with total bile acid concentrations greater than 100 micromoles, which would favor earlier delivery. So in refractory cases, these are the other drugs, although not very tried. S-adenosyl methionine administered, it's very inconvenient, very high doses has to be given intravenously, so it's not very practical. Cholestyramine, it's locally acting in the gut, it prevents bile acid resorption, so it results in steatorrhea, and then it can result in micronutrition deficiencies as well. So it has to be seen and has to be given in high doses again, 2 to 4 grams per day, maximum is 16 grams per day. Rifampicin is another drug which can be added to UDCA if the patient is very refractory to her pruritus, but it is a potent agonist of pregnein X receptor which mediates many detoxification and hepatobiliary processes. Relieves pruritus in non-pregnant patients with pruritus associated with cholestasis, but potential adverse effects including nausea, decreased appetite, hemolytic anemia, renal failure and hepatitis. So looking at these, we don't want to expose our women to more and more complications so that she has bigger perinatal morbidity. So these drugs are very sparingly used. Other drugs, these are basically to reduce the itching, symptomatic control. These are antihistaminics. Hydroxyzine 25 milligrams, we know by the name of Aterex. Chlorpheniramine 4 milligram every 4 to 6 hours can be, because the pruritus is relieved because they induce sleep. Calamine lotion or menthol lotion can be applied, but itching is widespread. Dexamethasone has rarely been tried, but yes, when the pruritus is so bad, it can be given for symptomatic relief. 12 milligrams orally per day did not improve pruritus or reduce the semen aminotransferase levels, but this is in various studies, it is different. Some studies say it is effective, but once we are trying to balance that, we are trying to move the pruritus is bad, but the bile acid levels are within our range, that is around 40, and we just want to tide over that period. So then dexamethasone can be given. So pregnancy management, antepartum fetal assessment is accordingly done at the time of when we have to time the delivery of the patient or when the diagnosis of IHCP has been done. It is and then it is always tied down with the bile acid concentrations. As the bile acid concentrations rise, the fetal morbidity keeps on rising proportionately. So follow all pregnancies in IHCP with twice weekly modified biophysical profiles and non-stress tests. Although these tests, as I said earlier, the stillbirth occurs very suddenly, so nothing would show up on these. It is only our mental satisfaction and the patient's mental satisfaction, but clinically we should know, we have to be very, very alert, because bile acid, probably the cause of fetal death is fetal cardiac arrhythmias, or maybe the placental vessels are getting occluded. We do not know, and these are sudden processes. There is no history of IUGR, there is no history of oligoamnios. Only meconium staining of Liker could be there, which has to be seen by an invasive process, which we are not ready to do for that patient. So we have to know that although we are monitoring the fetus, but the fetus is honestly still at a very big risk of morbidity and mortality. So the timing of delivery is what the patient's highest bile acid levels. As I said, if it is less than 40 micromoles per liter, although few deaths are seen, but it is very, very rare, we deliver at 37 plus weeks. And if it is 40 to 99, then we try to just reduce a week. 37 weeks onwards, we can deliver, if we can monitor the patients, if she is in a controlled manner, if she is very compliant and things are going smooth for her, we can go a little bit ahead. But once the levels have crossed 100, that is the time we stop. And the delivery has to be timed at 36 weeks. Rarely we have to go in for delivery at 34 to 36 weeks. It is when the patient is not responding to the treatment, pruritus is not responding, or liver transaminases are really going beyond the roof and liver symptoms are deteriorating, and we have had a previous history of IUD at that time. So these are the three indications we go in for a preterm delivery, 34 to 36 weeks. Another thing which is not in this slide I wanted to add, but I could not, that steroids have to be given, antenatal steroids, at 37 and 38 weeks. If not given earlier, they are indicated to be given in patients with IHCP. So total bile acid, this is the timing, is a summary. The total bile acid concentration less than 40 micromoles. When the highest total bile acid concentration during pregnancy is less than 40, we suggest delivery at 37 weeks onwards. And it should be, preterm delivery should be avoided. Total bile acid concentrations between 40 to 99 is the highest bile acid concentration during pregnancy is 40 to 99, then 36. We have just reduced 1 week, you know? So we start thinking of delivery at 36 week onwards, although we can stretch it later on. But once it is 100 micromoles, then we suggest delivery at 36 weeks and consider prior, that's what I was saying, when the patient has excruciating unremitting maternal pruritus not relieved, worsening hepatic function, or prior history of fetal demise. So this is RCOG guidelines. There is a little bit differentiation. In 19 to, they have started from 19 to 40, that is 19 to 39. Options are, we plan the delivery by 40 weeks, peak bile concentrations between 40 to 99, then the delivery can be taken up at 38 to 39 weeks, and for peak bile acid greater than 100 micromoles, the risk of stillbirth is highest, and the background risk, and consider planned birth between 35 to 36 weeks. So this is ACOG, nearly the similar ones. Less than 100 micromoles, the delivery is 36 week onwards till 39 plus, and for patients with total bile acids greater than 100, delivery is recommended at 36 weeks. So we have basically two categories. At 36 weeks, we are delivering only with greater than 100 micromoles, and before that, if it is for less than 40 or 40 to 99 also, we try to reach minimum 37 weeks of pregnancy. So maternal outcome in postpartum course, this is the beauty of this disease, it's just limited to pregnancy, and the moment the baby is delivered, the moment not the baby, is the placenta is delivered, all the symptoms start clearing away. So pruritus usually disappears in first few days after giving birth, accompanied by normalization of serum bile acid concentrations and other liver tests. Breastfeeding is encouraged For its maternal and infant benefits, ICP is not a contraindication. UDCA is discontinued after labor. Only small amounts will be ingested by the infant and are not expected to cause any adverse effect. And follow-up would be, we really have to follow up the patient. Her liver function tests have to be done, bile acid concentrations have to be done after delivery. If the patient remains symptomatic, then it has to be timed every 4 to 6 weeks, and if they stay persistently high, then the patient has to be referred to a hepatic unit. The special populations are pregnant patients with cirrhosis. So these are the patients who already have an underlying hepatic disorders. So here we are at very high alert. Measure the serum total bile acid concentrations during the second trimester, because chronic liver disease is a risk factor. One thing which is again missing over here, that bile acid testing is total bile acid. There are 3 types of bile acid: cholic acid, chenodeoxycholic acid and deoxycholic acid. We measure the total bile concentrations, and it can be done by mass spectrometry or liquid chromatography, but that takes 4 to 14 days, and enzymatic assays, they take 4 hours to 4 days. So it varies from lab to lab, and at times we are in urgency, so we have to really find out our lab which enzymatic assay the lab is using, so that we get the results in 4 hours or maybe 8 hours at the max, so that at least we can manage the patient. That is what we are depending upon. We are managing the patient on the bile acid concentration. We can't be sitting on for 4 days, that I get it done today and then I wait for 4 days and again I get it done wait for another 4 days afterwards. So patients receiving progesterone supplementation, again we just have to be guarded, and if the patient has had a background history of liver disease, ideally do not give progesterone supplementations. So in summary, diagnosis of ICP is based upon pruritus associated with elevated total serum bile acid. So these are the only 2 hallmarks of this disease, and elevated aminotransferases can be seen, or both, an absence of disease that may produce similar lab findings and symptoms. They are the DD for it. Pruritus usually begins in the 2nd or the 3rd trimester, ranges from mild to intolerable, primarily affecting the palms and the soles, and is generalized and is worse at night. It can precede rise in serum bile acid by several weeks, and severe cholestasis, defined as bile acids over 40 micromoles, accounts for about 20% of the cases. I have been the sufferer in my 2nd pregnancy. If ma'am would remember, I had severe IHCP and my aminases were 1500, to the tune of 1500, and at that time I don't think so we were doing bile acids were not being done. Yeah, this has come now. So now the things have become, and another marker is coming, that is autotaxin. It has been seen in the lab animal models, but it is very specific to pregnancy and OCs. So if that marker comes, it will be very, very specific for IHCP. That name is autotaxin. Secondly, these IHCP women are more prone to gestational hypertension also, which is seen to be the tune of 5-fold. And that gestational hypertension comes, the pruritus comes first, lab abnormalities come second, then proteinuria comes, and then BP rise comes. So this is the sequence of events over a period of 4 to 6 weeks. So we have to be very alert. Also, they are prone to GDM as well. So pruritus helps distinguish ICP from other types of pregnancy related disorders characterized by elevated aminotransferases, that is HELP syndrome, preeclampsia with severe features, acute fatty liver of pregnancy. Lack of primary skin lesions in ICP helps to differentiate it from most pregnancy specific pruritic dermatosis and skin conditions unrelated to pregnancy. The fetal effects, that is the major part. The major complication of ICP are fetal or neonatal, that is increased risk of intrauterine demise, meconium stained liquor, preterm birth, both iatrogenic and spontaneous, neonatal respiratory distress syndrome, and the risk of stillbirth is highest when the bile acid concentrations breach 100 micromoles per liter. So maternal treatment is UDCA. Although we in pregnancy we are saying the mother is not at risk, but she is postpartum. She is a person during that 1 year postpartum, she is at risk of more liver diseases. So UDCA relieves pruritus but has no known fetal and neonatal toxicity. It's well tolerated and it is only relieving pruritus mainly. Bile acid and transaminase level falling is incidental, it's not very significant. So if UDCA is started empirically, we have not to start. This is another Society of Fetal Maternal guidelines that do not start empirically UDCA, otherwise we will miss the rise in bile acids and we will not be able to follow the patient honestly. Timing of the delivery is based on the total high serum bile concentration, less than 40 micromole. We can go up to 38 weeks and 39 as well. Highest bile concentration is 40 to 99. We look at 37 and 38 weeks, we decrease 1 week, and highest bile concentration we stick to 36 weeks, and 34 to 36 only when there are special indications. So maternal outcome, pruritus and lab abnormalities rapidly dissolve after delivery. Liver functions and bile acid concentrations levels should be rechecked if the patient continues to have clinical symptoms after delivery. If these symptoms do not return to normal, the patient should be referred to a liver specialist. Cholestasis recurs during subsequent pregnancy because I told you the reason is genetic and hormonal, and both the things, the woman is the same and she could have again. To the 60 to 90%, it is written only 70, 60 to 90% cases, recurrent episodes are variable in severity. Thanks.